Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and I've been away a little bit. I was teaching in Sydney, Australia, a lot of peripheral nerve entrapment material. And then I guess I either felt like I had nothing relevant to say, or I just didn't feel motivated to put down some ideas. And so I'm going to tell you about a recent pain case. I just saw him for his fourth visit. When someone comes in chronic pain, I usually tell them expect to need 3 to 5 sessions to get the best results. And based on how you're doing after the first 1 or 2, we'll both have an agreement on, how we're proceeding. And if there's going to be more than 3 to 5, we'll make sure that we agree that it's helpful and worth working on beyond 5 treatments. There's a man in his 30s, so I really didn't expect to need more than 3 to 5. But history of back pain and sciatica, and it really kicked off after slipping and falling on the ice. So he landed on his right glute and started having back pain sciatica. So went to the doctor. They did an MRI eventually. Of course, they did all the preliminary stuff first. They did an MRI. They saw that he had a disc bulge, and they recommended that he have surgery for the disc and do a discectomy. So he has a very small incision right around L5 where they did that surgery, and the sciatica went away, but then he felt after surgery like all of his muscles were super tight, and it just didn't feel right. Shortly after that, he started having pain on sitting and burning in the upper glute, burning in the lower glute, and the pain started coming back that went down the leg. And so, of course, he went through physical therapy. He saw other doctors, other experts, and by the time he came to me, he really wasn't having a lot of faith that I could help him. But his wife was with him, and she, I think, had been the person who was sort of keeping his hope alive and keeping him moving forward to keep trying to get better. And she'd done a lot of online research trying to figure things out for him because nobody was able to really give him good answers. So she had actually heard of the superior cluneal nerve. She knew a little bit more about pudendal nerve, things like that. So they came in, and from the intake, all I knew was that he was having this sciatic pain and low back pain, and it was all right side symptoms. Upon palpation of the deep rotators like the piriformis and the gemelli and the obturator internus, everything was super sensitized. He had burning along the upper glute, sensitivity on the iliac crest on the right side, some sensitivity on the right QL, a lot of sensitivity in the right gluteus medius. So I did some muscle testing, especially things like psoas. I like to know if the psoas is shutting everything off in the back and making the deep rotators work harder, and also putting in an increased anterior pelvic tilt, straining the SI joint, making piriformis deep rotators get tighter, hamstrings, etc. And his psoas definitely was involved. So on the first treatment, I treated like I normally would for sciatica and a superior cluneal and entrapment. So I treated the QL, the gluteus medius, the piriformis, the lower rotators, the obturator internus, and the gemelli all in one point. That's all described in a different podcast that I've done. Um, Biceps femoris and peroneus longus with electric stimulation for 10 minutes. Take the needles out, have him stand. Still a lot of pain. Most of the pain seems to be in the gluteus medius. And that made sense to me for superior gluteal symptoms. So I did trigger point release on, I think, 3 different taut areas of the gluteus medius, and made sure that they were no longer painful after the trigger point release. Um, I did a little bit of a trigger point release on the QL, because if I find sensitivity on the QL, I'm suspecting that's the first point of entrapment for the superior cluneal nerve. So I did that, and I think that was the end of the session. And we talked, and I was getting more of the background of everything that happened and how he had fallen on the ice, etc. Um, so I expected the next time to see him and that he would be feeling much, much better. But in fact, he started texting me a couple days after to tell me that he was still in pain and it was still not possible to sit. Still a lot of pain in the lower rotator area. So I said, okay, so there may be some trigger points there. We will address that when I see you next week. So I saw him, and he was really hyper fixated on the pain that he had in the lower glute area, and had seemed oblivious to the fact that we had cleared away all the burning of the upper glute, all of the pain in the glute medius area, all of that area. So, because all he could think about was how it still hurt, and so I was saying, okay, this is progress, even though you're still miserable. Um, so what I found was 2 really taut bands, probably separate muscles. Like obturator internus was one of them, and I know superior gemellus was the other, because he had the sensitivity of the superior gemellus up close to the sacrum, below the piriformis, where I like to get some twitches when there's a sciatic referral to the low leg. So I did trigger points. I treated all the same muscles that I just told you about for the first time. We did QL, gluteus medius, piriformis, lower rotators, hamstring, peroneus longus. I did not release his psoas the second time. I don't always put people through that every week because I know it's a little jarring. So I left that out. And I did trigger point release in the obturator internus, and I believe it was a superior gemellus, like I just said. And while I was doing it, I was telling him, because I knew he had this piriformis issue as well, that was causing sciatica. I said, these trigger points in the obturator internus could have also irritated the pudendal nerve and given you other symptoms like urinary urgency or rectal discomfort, or could feel like what they say, like a golf ball in the rectum. You could have pain on defecation. There's all sorts of things, burning. And so then the truth comes out. Then he said, "How? Okay, so these are the symptoms that he was complaining to the doctor about, and they didn't have any answers for him." So he and his wife and I were in agreement that this was the right track, that it was, we were on the right track. And he said he still got burning in the lower glute area, and it would go into sort of the rectal area, like burning, which sounded like inferior cluneal to me. So I said it could be pudendal symptoms, but there could also be this lower cluneal. Plus, you had the sciatic referral. So there's a lot going on here. It's not. It is complicated, and it makes sense that no one was able to help you because in the area that I live in, I don't know of any experts for peripheral nerve entrapment. So it can be really kind of tricky to get a correct diagnosis for something like that. Um, so he was texting me again a couple days after the treatment to tell me it was still flared up. Why is it so flared up? He's asking. I said, well, I did dry needle those trigger points that are right up against the cluneal and the sciatic and the pudendal nerve. So the inflammation is probably reproducing the symptoms you're having from it being too tight. And so he would he texted me the next day. He said it's still flared up. I said, okay, sometimes these things can take several days to heal. Trigger points, they say, are healing up to 14 days, and sometimes people do have symptoms beyond 2 or 3 days. Not usually. Usually it's my older patients. I told them usually it's my older patients that have symptoms that go to 7 to 10 days after trigger point release, but it is not unheard of. So do not panic. We will sort it out. And I offered to have him come in for at no charge for me to just do some electric stimulation on the same muscles, because my experience with that post trigger point pain is that if you treat the motor points then of those muscles, that is going to neuromodulate that pain. You're going to have the pumping of the electric stimulation on the motor points that's going to clear the inflammation. They can walk out like pain free after you do that if they're having that big flare up. So I said, if you have the time, come at the end of my day. It'll take us 10 minutes and I'm not going to charge you, and then you'll feel better. He said, I can't make it. I can't make it at that time. So I said, okay, don't panic. He said, it's really, I'm not saying you're doing anything wrong. I'm just saying I've been so frustrated with all the people telling me that they can fix me, and then it's not better. And I just get worried that there's nothing that's going to ever fix me. So I said, no, I totally get it. But everything you're telling me and everything that we're seeing seems to line up with this diagnosis. And I really think this is the right way to go. So he had taken some sort of, I forget what he took. He said, it's been so bad. I took a blah, blah, blah. I don't know. It was like probably like pain medication. I said, if you really want to help with confirming diagnosis, get a lidocaine patch, put it on your lower glute, and see if it relieves the burning symptoms, because that'll tell me if it's a cutaneous nerve issue like the inferior cluneal nerve. And if it doesn't help, then we know it's more likely a pudendal involvement. So the lidocaine actually was helpful. So I saw him for his third visit. He and his wife came in, and the lower rotator symptoms were gone. The only thing left, and I told him, oh no, sorry. Okay, I'm jumping ahead to the fourth visit. The third visit, the lower rotator pain was gone. But we were talking about how I had told him in the process that when we get him out of pain, he needs to relearn how to use his glutes correctly so that he's not using these deep rotators so much, because he's a big fan of going to the gym. He was working out through this whole process. He knew that he had irritated the lower rotators by doing some abduction exercises. So like he was doing some bridging up and out and doing some clamshells, and it really irritated. And we talked about it, and I didn't want to tell him don't go to the gym, because part of what was depressing him so much about this whole condition was his feeling that he can't work out, and he really wants to work out. So I said, okay, it's going to be a little 2-step forward, 1 step back, but you got to retrain your brain to know how to use your glute max, because it's your brain has stopped using your glute max. It's Stuart McGill calls it gluteal amnesia, and he was very familiar with Stuart McGill because he and his wife been studying so much about back pain. Okay, so what I saw with electric stimulation on glute max was revelatory. Normally, I'm going to say 90%, 95% of the time, if you release hip flexors like the psoas, TFL, rectus femoris, even sartorius, you're going to help the glute max to fire better. It's just being reciprocally inhibited by the tight hip flexors. But this was not the case with him. I saw um, the muscle test for glute max was still super weak on that side, and we agreed that I would use my favorite technique, which is high frequency discontinuous on my Pantheon. So I set the Pantheon to 30 hertz and I turn it to discontinuous, which is like 3 seconds of contraction and 3 seconds off. Um, and I had to crank it. Well, I was only slowly raising it. Okay, I had the point in the glute max motor point. I had confirmed my location with my pointer device. I knew I was in the right spot. I was using the pointer at a high frequency, like 10 or 15 hertz, just to kind of get the glute max waking up. And I'd put two different needles in, one near the top of the gluteal fold, like 4 fingers out, and then another in a lower glute max area, also thinking about that lower cluneal area. Um, so I had 2 points in, and then I really cranked it. The Pantheon goes up to a 6 on intensity, and I really got it up to like a 5 to finally get good strong contractions. And then after that, I used my pointer again at a high frequency with some pressure on the muscle, because when you put pressure on the muscle that you're stimulating, it increases the ability to get good contractions. So I was doing that. I got to that level I like to see, where you get like 2 contractions. You get a strong contraction, and then it turns into an even more intense, like almost like a muscle cramp at the top. Um, which is what I want to see to wake up a muscle. Now, my theory is that when he fell on his butt on the ice, that he injured that inferior gluteal nerve, or the piriformis began to compress it more, and it had become totally inhibited either by the pain of the accident or some sort of compression injury at the near the sacrum, near the piriformis. So regardless of how it happened, it had happened. His glute max had really shut off. And how he discovered that it was that shut off was that I told him that he needed to start squeezing his glutes when he went upstairs at home. And so he was starting to try to do that and realized that he really could not engage his glute. And he was just trying to do some light bridges. And we had been texting about it, about like bridges and is this going to irritate? I said, if you're just going light, if you're not using you're not doing a lot of weight, you're not going to use the compensation muscles. It's just to feel it squeeze. Just squeeze your glute so your brain can connect to the muscle, so you can build new pathways that remember how to use your glute max. So once we got it woken up, the next time I saw him, it was firing great. Now he does still need to strengthen it because it's been shut off a couple years, I think. So he's working on it. But okay, so 4th visit, he's doing way better. Now he did text me after that visit, like the day after, because he was having pain again. Well, he said, "Why does this flare me up so much?" And I said, "Okay, well, we're going to see how you feel in the next day or two. Let me know if it's not better. I think you're just having the normal flare up of one day of soreness. I really hit your glute max hard, and it was firing really well, but I probably kind of wore it out and may have caused some serious muscle soreness. So do not judge it yet. It's too soon. Wait, see how it goes." So he didn't text me back. And I wasn't going to reach out because I wasn't really, I feel like give him space. He's processing a lot. If he's not feeling better, I don't want to emphasize that by reaching out and having him say it again that he's not feeling better. So he came in with his wife on the fourth visit, and the only thing that still hurt was a trigger point in his piriformis near the sacrum. The burning was gone. He wasn't getting burning pain. He was his concern was it was still hard to sit because the piriformis trigger point was still referring some pain down to the lower glute area. So I did trigger point I did motor points on the piriformis first just to loosen it up so that whatever I'm feeling I know is trigger points. He had one taut band that was irritated in the piriformis that I was able to deactivate. And I did, for a second time, I grasped the lower glute where it turns into the tendon before it goes down to its attachment at the back of the femur. So there's that it's the area that can kind of irritate the lower inferior cluneal nerves. So I did grasp that and put a needle there and did electric stim it just to be sure. The pain he was feeling in his leg from the piriformis, he pointed to where it was, and it's pretty sure it's the tendinous attachment of that lower glute max area that attaches to the femur. Upper 2/3 of glute max attached to the IT band. The lowest third is attached to the femur to help with external rotation. So I'm feeling pretty optimistic that I'm going to see him and he's going to be doing way, way, way better. And I think he's on board. He realizes that, this can get better for him, which I think is the most important thing. Is just, he had really lost hope. Like he's just thinking, nobody can fix me. No one's going to be able to fix me. And he wants to exercise. He wants to play sports. He wants to do things that he has not been able to do for 2 years. It's been more, I think, emotionally difficult for him, even though it's got to be horrible to have to stand at work all the time because you can't sit. But I think it's just been playing a number on him. He's like mid-30s, and he feels like he's been crippled by this experience. So I kind of wanted to tell you the story because not everything is easy like roses when I'm treating complex pain. Even if I'm right about the diagnoses, and I kind of flip-flopped around on which nerves were involved, but I knew what targets I needed to treat. And even though I think I was making really good progress, he was not feeling like I was making good progress. We were seeing changes in the symptoms and the areas that were causing pain. And because he still had pain and it's still hard to sit, he didn't feel like it was any better. But I was seeing all the things that he came in with go away, like the burning in the upper glute and the pain in the glute medius and the low back pain, etc. So the last time I saw him, the fourth visit, treated the trigger point in the piriformis, and I did release his psoas again on both sides because he was still feeling some tension in his low back, and it was like QL area. So I treated the psoas. And I think there was like one other thing that I treated on him, and I can't. Okay. I did also treat the antagonists, the TFL, and the gluteus minimus, because one thing he really wanted to be able to do was a figure 4 and not have any pain and not have so much restriction. So we had improved his hip internal rotation, but his hip external rotation was still pretty tight. So I did treat those for the mobility and also because they're antagonists to the deep rotators. So I'm feeling pretty optimistic for him. I'm feeling like we're really making good progress. And it was after 4 visits that we got here. So next visit is fifth visit, and I think I'm right on track for what I predicted for him, which I feel pretty good about considering he came in with something that I think nobody in the area was recognizing and or able to treat. First, you got to recognize it before you know how to treat it. So I feel good, and I'm hopeful for him, and I'm looking forward to hearing great things about him getting back to exercise and being able to get his glutes firing so that this sort of thing doesn't come back. So, anyway, so I hope somebody out there found that interesting. And um, you can always Google superior cluneal nerve entrapment, inferior cluneal nerve entrapment. There's a lot you can find for free out there. If you're not using AI for your deep research, I highly recommend it. I use Gemini Deep Research. It is um, next level for what you can learn about what research is out there. You don't have to read all the summaries anymore and then find out there's a paywall and that you can't get to it. You can just use Google Gemini AI deep research. Choose the deep research option. It will it will not only find all the sources and list them for you, it will go out and read them all, summarize them in a report with um, formatting and tables, and then all the research, and it just summarizes everything for you. And you can even ask questions. You can change the way the research is structured to include something else. I mean, you have to use AI now, and you're going to learn so much about your patient's conditions that you're struggling with, the things, the terms that, and things that I'm talking about. You can look it up and find out more. It's out there and it's free. I mean, there's nothing better. We live in an amazing time. So when you take interest in something orthopedic and you have questions, use your Gemini AI, and you will learn so much so fast. You don't have to just read things on Google anymore. It will do it all for you, and it'll narrate it. Oh, and by the way, if you're not using, if you're not using Notebook LM from Google, then you're missing out. You can feed research papers into as sources into Notebook LM, and then it can turn it into a podcast of two people talking about the topic. It's incredible. It's pretty amazing. So use those tools out there. Okay, that's it for today. Um, yep. I hope that was helpful, and I will talk to you soon.